So movement disorders, they seem to be a slightly different game than Alzheimer's disease. Movement disorders, particularly, I would say, Parkinson's disease. There is a very strong standard of care right now. Levodopa is a very strong medication that exists that can significantly and immediately alter symptoms in Parkinson's disease. So what we've seen with Nilotinib and also with other TKIs like Nilotinib in dementia with Lewy bodies, which is really a memory and a movement disorder, we've seen that Nilotinib again inhibits DDR1. When inhibits DDR1 induces autophagy. It does actually have this significant effect on microRNAs, particularly in Parkinson's patients. Something that we didn't know before. We didn't know that if you like, angiogenesis or blood-brain barrier defects are so prominent in Parkinson's disease as they are, as we know, let's say in Alzheimer's disease, where probably 2 out of 3 patients with ApoE mutations or ApoE not mutations, ApoE alleles, 2 alleles of ApoE will probably have more inflammation and blood-brain barrier. So what we've seen in Parkinson's disease, we've seen the effect on these biomarkers, and notably and very significantly in several diseases right now, including Huntington's disease, Parkinson's, Lewy body dementia, and Alzheimer's disease. These TKIs somehow have an effect on the level of dopamine, on the level of endogenous dopamine. And that probably mainly due to the effect of these TKIs on the breakdown of dopamine. So that would make more dopamine available, particularly in diseases like Parkinson's disease. If you have loss of dopamine, then that would probably compensate for that loss of dopamine due to a reduced breakdown and making more dopamine available to the brain. But because of the standard of care, because of levodopa, because of the immediate powerful effects on the symptoms, the effect of Nilotinib in Parkinson's disease is not seen immediately, particularly that until now, we've only studied Nilotinib in patients who are moderate Parkinson's disease patients or severe end-stage Parkinson's disease patients. We have not studied Nilotinib in early disease stages. So we've seen that the drug sufficiently enters the brain, inhibits DDR, and importantly, you're only seeing the effect on motor symptoms over a longer period of time, maybe over 1 year, because in the first year of the trials that we did, we've seen that the effect is minimal, and there's actually a lot of placebo effects over 1 year at least in Parkinson's disease. But as we went out to 27 months, we've seen that the Nilotinib completely reversed the effect or motor, if you like, the decline of motor symptoms in Parkinson's patients. So that said, is we have 2 options here for Nilotinib: either to go to an earlier stage of Nilotinib, an earlier stage of Parkinson's disease, where Nilotinib is administered in levodopa-naive patients, and we would look at the effects of Nilotinib in these levodopa-naive patients over at least 1 year to see if the potential disease-modifying effect that we're seeing with levodopa can delay or prevent, if you like, taking, if you like, the levodopa therapies. Alternatively, if we are keen on basically studying Nilotinib in patients who are already on dopamine replacement therapies like levodopa, then our clinical trial will have to be at least 2 years to see if there is any effect of the drug over 2 years, on top of levodopa. So it's exactly the same concept as we do in Alzheimer's disease. In Alzheimer's disease, we want to see if the drug has any additive effect on top of the standard of care, and if it can basically counteract edema or ARIA, in amyloid, anti-amyloid therapies. In Parkinson's disease, we either have to start very early on before patients are on levodopa, or if they are on levodopa, we have to study them over two-year period of time to see if nilotinib on top of levodopa can halt or reverse motor effects. In both Alzheimer's and Parkinson's disease, we've done phase 2 clinical trials, and phase 2 clinical trials have if you like, led to very, very highly encouraging effects, particularly on biomarkers like ɑ-synuclein, dopamine, microRNAs, amyloid PET, CSF amyloid, volumetric MRI. This is all good, but none of these clinical trials have been adequately powered to show the clinical effects of the drug. There is, in Parkinson's disease, a strong indication that over a longer period of time, in patients who are taking levodopa, there is a complete halt of neurodegenerative, or if you like, of movement disorders progression. In Alzheimer's disease, we're still yet to see this, but my guess is considering the multiple effects of the drug on the pathology of Alzheimer's disease, we are likely to see a clinical effect in an adequately powered phase 2 trial.